yourself. Yeah, I already got them, so just when we get that hard, let me know and I'll start it up. Good afternoon, everyone. My name is Dr. Roger. I'm the Joint Nutrition Director here at the Regional Medical Center. So we're going to talk a little bit this afternoon about solutions for knee pain. Knee pain, of course, is a pretty common thing in all ages, but as we all get a little bit older, our incidence of knee pain also becomes more common. So arthritis certainly is a very common thing that orthopedic surgeons deal with. Certainly in the United States and in all industrialized countries, people are getting knee arthritis at an increased rate. This is the knee joint here, and this dark area right here is an example of a normal knee joint space. And when the normal knee joint space gets narrow, then you end up looking like the knee joint looks on this side, where you have this so-called bone-on-bone configuration here. This, of course, is the thigh bone, and the leg bone is down here. There's actually two leg bones, and where those meet is where the knee joint is. And this x-ray over here is a side view of the knee, also called a lateral view of the knee. And this is where we are able to see some arthritis in the kneecap region here as well. So the symptoms of knee arthritis are pretty consistent. It causes knee pain. It causes difficulty doing activity-related things like standing and walking, going up and down stairs. For people who do hiking, it causes pain there as well. So the other thing that knee arthritis can cause is a feeling that the knee might not support you, a feeling that the knee might give way on you, and that's another symptom for people who have arthritis in the knee. Generally, we try non-surgical treatment for patients who have arthritis of the knee. Medication, which are freely available these days, are frequently used. These usually include anti-inflammatory medications, ibuprofen, naproxen, those kinds of things. There's some fancier, newer ones, like Celebrex and the COX-2 inhibitors that we can try as well for that. And that can give some relief of knee pain depending upon the severity of the arthritis. Physical therapy can also be very helpful. Strengthening the muscles around the knee and learning good biomechanics for the knee can also be helpful in terms of lessening the knee pain and improving somebody's ability to walk. We also frequently recommend a cane or a walker. It helps with balance, and it can help with a sore knee to lean on a cane or a walker a little bit. And then if we can identify certain activities that we know are going to aggravate the knee, for some people that's playing tennis, or for some people it's walking on hard surfaces, for some people it might even be shoe wear, we try to avoid those activities. And then an additional thing that we frequently use would be injections into the knee. There's several different types of things that can be injected into the knee. And so depending upon the type of arthritis and the constituency, those are things that we adjust as well. Can you all hear me okay? Okay, good. For patients who have arthritis of the knee, a brace of the knee can also be helpful. This is something that can help stabilize the knee. It can help you be a little bit more careful with the knee. And it's something that can make you feel a little bit better trying to get around with a sore knee. There's generally very little downside to trying a brace, so in many cases it's something that can be useful, and it's not invasive at all, and that's why there's very little downside. So of the different kinds of injections that we contemplate, certainly a cortisone or a steroid injection is the most commonly done one. This is something that decreases inflammation in the knee, it decreases pain in the knee, and it helps you get around with a little bit less pain. A newer medication that is put into the knee joint is viscosupplementation. This is the two-bit name for that is called hyaluronic acid injection. This is a substance that is kind of an analog for cartilage, and in patients who have mild to moderate arthritis of the knee, this can be helpful in terms of improving the symptoms from knee pain. Something even newer than visceral supplementation is platelet-rich plasma and stem cells. These are generally still considered to be experimental, but they are being done in centers around the world. They'll generally harvest some stem cells or platelet-rich plasma either from fat cells or from your blood, and then they spin it around in these fancy machines and then inject that into the knee in order to see if those new cells can help regenerate or rebuild some cartilage or tissue inside the knee. Knee arthroscopy is also something that we consider for certain disorders of the knee. Arthroscopy works the best when there is predominantly a torn cartilage in the knee without much arthritis. If you have a knee that has a lot of arthritis and if it also has a torn meniscus, those knees don't tend to do quite as well with arthroscopic surgery because in those knees, the main problem is still the arthritis of the knee and not the torn cartilage of the knee. So if you have arthritis and a torn cartilage that exist together in a knee, sometimes arthroscopy is not as helpful, but if you have a knee that has just a torn cartilage and only minimal arthritis or no arthritis, then arthroscopy is very beneficial for those patients. Now, those are the less invasive, minimally invasive arthroscopic procedures and injections that can be helpful for knee pain. But if we look back, certainly historically, surgeons have looked at many different ways in order to treat knee arthritis pain in a longer term way. So surgeons frequently ask, how can you relieve knee pain for patients who have severe arthritis? And prior to the 1950s, this was done predominantly by fusing the knee. When you fuse a knee, you actually take a metal plate or other device and you create a circumstance in which you make these two bones grow together. Now, when those bones grow together, you can no longer bend your knee. But the knee pain actually goes away pretty good. And this, in the 50s, was considered a pretty good treatment for knee pain. And it gave great pain relief, but it's a little bit hard to walk with a stiff knee. So this very innovative thinker, Sir John Insull, was very interested in disorders of the knee, and he's considered the modern godfather of knee replacement procedures. He was originally English, but he ended up in New York, and he developed some of the early foundational designs for knee replacement right here in this country in New York. But when he initially did this, he had a lot more questions than answers. They didn't know what shape to make a knee replacement. They didn't know what size to make a knee replacement. They didn't know very much about knee movement. We've learned a little bit since then about how the knee actually moves. And then stability was, of course, a concern. And in addition to all of those things, they didn't know what to make the knee replacement out of. They didn't know if they should use stainless steel or maybe tempered glass or high-grade plastic. So there was a lot of questions that Dr. Insull was involved in initially in the early history of knee replacement design. Then the second question, after we find out what kind of knee replacement design we're going to use, is how are we going to get it into the body? How can we get it into the actual knee joint safely? So the early designs of surgery for placing knee replacements had these very traditional approaches to surgery. The first one that Insull recommended was to actually cut the muscle, this is your quadricep muscle, right down the middle and go right over the top of the patella. And he thought that was the best way to get in and out of the knee. And it did give you good exposure of the knee. You could see the knee pretty well in that case. But it hurt a fair amount after surgery, and it did have a fair amount of bleeding that was associated with that as well. So surgeons subsequently asked, is it possible to do a knee replacement without cutting any muscle? Is that possible to do reproducibly? And the answer is that it can be done. Some of this work was done in Germany about 30 to 40 years ago, and it was a technique about getting in and out of the knee joint without cutting even a single muscle fiber. And if you can do that successfully, then you'll get faster healing, less pain, and a lot better early walking especially. So this traditional quadriceps muscle was incised right down the middle. But nowadays, what we've been doing here for more than a decade now is to actually go in the side of the knee joint here we lift up the entire muscle and move it out of the way so that we can get to the knee joint and do the knee replacement. And now we put the muscle, turn it back over and put it back down there. And this can be done without disturbing even a single muscle fiber. So this causes a lot less muscle damage, less pain, and a much faster recovery for patients. When I first learned knee replacement surgery about 25 years ago, it was pretty routine for patients to stay in the hospital, maybe 10 days, even up to 2 weeks. That was pretty standard in those days. Nowadays, about 85% of our patients are out of the hospital walking on their own in less than 24 hours. So that's a big difference that we've seen just in my 25-year career so far. This Vastus approach, we've done about 2,000 of these knee replacements. I've now taught this to a number of other surgeons from around the country who become very interested in it. It gives you a great look at the knee joint so you can safely put in the knee replacement. There is minimal, if any, muscle trauma so that there's less pain and a better ability to walk afterwards. There's much shorter hospital stays, as we just mentioned. Hospital length has probably come down 70 to 80% or more. And there is certainly a faster recovery in terms of somebody's ability to walk early right after a knee replacement. The other thing that this surgical approach and combination with other management factors has done is it's been a great improvement in postoperative pain. So in the olden days, if you cut that muscle right down the middle, boy, that hurts a lot after surgery. So you have to take a lot of pain medication, and the pain medication, even these days, is not that good for you. It makes you kind of sick, and it stops you up, and it's really has a lot of side effects that are better avoided. But a less traumatic surgical technique, in addition to some advanced pain management strategies, is used to help prevent pain rather than treating it after it gets here. Another question that comes up frequently in knee replacements is how long do knee replacements last? There's a lot of different factors to answering this question, but the longevity of the knee replacement to some degree depends on how much stress you put on. So if you look at studies of people under 50, for example, they don't last quite as long in that age group as they do in folks who are perhaps about 60 and over. Nevertheless, most knee replacements these days generally would be expected to last 15 to 20 years. And what we mean by that is that about 85 to 90% of knee replacements should fall into this category. We know that the metal and the plastic is now better than ever, and in addition to that, the designs now are better than ever. So what Johnny Insull started those many years ago has been evolved and improved over time to give knee replacement designs and materials a much better effect in terms of lasting as long as possible. So since 2004, we've done over 2,000 patients here using this Vastus approach. We found it to be very consistent, a lot less pain, a lot less bleeding. We found our transfusion rates went down dramatically. If you look at the published rates of getting a blood transfusion after a knee replacement, it could be as high as, well, when I first trained, it could be as high as maybe 50 to 60%. But we just looked up our results using some of these techniques and other strategies, and our transfusion rates are down under 2% now. So we'd say that most people have about a 98% chance of not needing a blood transfusion after this type of knee replacement surgery. In addition to that, our facility here and our program here was recognized by two different recognition groups. One is the Joint Commission, which evaluates centers that do knee replacement, and it will award them a Center of Excellence designation if it meets certain very strict criteria. So we got a Center of Excellence designation from the Joint Commission several years ago, and we have maintained that through this time. And then about a year and a half ago, we also got designated by Healthgrades as being the top 100 hospitals for hip and knee replacement. And that was another recognition of our results here that we get through our approach to less invasive, enhanced recovery knee replacement techniques. Now, sometimes a picture's worth 1,000 words, but a video is probably worth even more than that. So one of the things I like to do sometimes is to videotape patients after surgery. So we videotape some of our patients at 24 hours after surgery. So this gentleman had a knee replacement, and we videotaped him the next day in our new joint spine pavilion. So this is him at 1 day post-op after a complete knee replacement. So you can see he walks pretty confidently. He doesn't have a cane or a walker. He had a minimal amount of pain. He can turn on a dime, of course, and he able to do very well following this enhanced recovery, minimally invasive knee replacement technique, which incorporates our surgical procedure in addition to other pain management strategies to help get people back on their feet as quickly as possible after knee replacement surgery. So that's the general outline. Here's another lady who also, we filmed her at 24 hours post-op. And you can see she also able to walk without a cane or a walker, very minimal amount of pain. And she's able to walk the length of this hallway without any difficulty at all. So these are not unusual results, so we tend to see these results every week by and large. Another individual here, 24 hours post-op, and she's feeling pretty confident there on her brand new knee replacement. So we're very happy to see this kind of fast recovery from these patients who are undergoing these knee replacement procedures. Okay, does anybody have any questions?